whenever I shoot my cross-table lateral C-spine, I always see the mandible and it looks good. He says, I just used a cross-table lateral C-spine technique at 60 inches, and he said it came out great. So think about what may be on that image somewhere else, and if that's there, then you can use that as your technique. Does that make sense? So again, it's kind of playing that association game instead of just trying to think outside the box completely. And then communication is important, and it's important in a number of different ways. You want to try to be able to anticipate what the doctor wants, so if they say, like sometimes they'll just stand back, and that's understood that now you need to go to a cross-table lateral. So you can say, you want me to do that. If you don't anticipate and they have to tell you, they'll let you know, like, hey, listen, I don't want to do the thinking for you too. I've got enough to think about. So always try to anticipate what they need, and also keep in mind, you might be real hesitant to want to do certain things, like for instance, you're doing a cross-table lateral lumbar and the patient's real big. You might think, well, do I shut the respirator off or do I not? Do I not? You'll probably need it off. Ask to turn it off, okay? Because if you don't turn it off and there's motion, they're going to let you know afterwards, okay? If you see something in the way, there's a hemostat in the way, or there's some wires, ask for that to be moved, because otherwise, you shoot the image, and they'll say later, next time you need to move those wires out of the way, that's really distracting. It's an artifact. So they're going to be upset with you one way or the other, but they'll be more upset after the image. So I would go ahead and say something in the beginning. They're going to rush you through stuff. I would be setting up for some kind of cross-table lateral. They would close the door and then open it about literally 3 seconds later. It's like, you done? It's like, haven't even moved the tube yet. So stand your ground. When they see that you know what you're doing, they'll respect you. And again, they're kind of just testing you out a little bit. I hate to say that. But anyway, that's the main thing I wanted to talk about on that. I don't really need to go over this here about the different sterile garb and that. Have you ever seen where they call a timeout in the room? Okay. So it used to be where they only call a timeout if there was an issue. Okay, so if there was a problem, then they would call a timeout. Now what they're doing is they're just calling a timeout at the beginning. And again, this is where the nurse, the circulating nurse will read out, okay, this is, Mr. Jones, we're doing a left hip, he has allergies for this, does anyone have any issues in that? And so they really can't begin the case now until someone calls a timeout. Okay, so let's go on to this here. This is just a suggestion. Whenever you have anyone has put on these sterile drapes on the top, okay, make sure don't tie it. You can certainly touch this with your hands. Don't tie this too tight, because when you turn it into the cross-table lateral, it can really stick in terms of, going down into the unit and that, so be real careful. One other thing, if I could make a suggestion, I'm going to kind of jump to this other slide here. What's going to help you out with cleanup here, and I know there's some people that aren't looking at the screen, so I don't know what you're looking at. So if you want to look up here, that'd be great. You might want to put like some kind of baggie over the bottom, because what happens is there's all kinds of stuff, blood and all kinds of fluids that will drip down. You bring this out afterwards and you got a lot of cleanup, okay? If you put a baggie over this area, which a lot of times isn't going to go into anywhere close to sterile field, you take the baggie off and you are done, and it's such a quick cleanup. Can't tell you how many times that something's on this end of it, you don't see it, and you go ahead and do your cross-table lateral, and they can see it on the other end, like, you need to get that clean. That's someone else's blood, It's supposed to be like the cleanest thing ever, and you got someone else's blood on the bottom because someone didn't clean it up. So just kind of keep that in mind there, okay? All right, there's all the equipment. Some of the things here I wanted to mention here. You've got a number of different, we've got the monitors. I'll talk about that in a minute. Last image hold, usually it's set on that. Make sure it's set, because that's a radiation protection. Otherwise, the screen will go blank. So it usually should be preset, but make sure that is. Edge enhancement. This is kind of an interesting thing. We have this. If you're doing any kind of surgery and they want to see a fracture just along an extremity, you can put that on an edge enhancement. It'll look very pixely, but you'll be able to see that fine detail. And it helps out really to be able to see that. The doctors really seem to appreciate it. let's talk about some of these in here, and I talked with Bob, and Bob, thank you again for the information on this here. You have different things, you've got your foot pedal here, and what's nice, Bob was saying, is that a lot of the places, the doctors use the foot pedal, and that's really best. Otherwise, the responsibility is on you, and they'll be, asking you to start the Fluoro. Again, they'll use terms like, with me, they would say flame on, or, it sounded like a cartoon thing. It's like, or, X-ray, or whatever. And so, it'd be your responsibility to activate that. So magnification mode, they're gonna tell you to do that, okay? Just keep in mind, it will magnify the image, but it's also going to increase the dose for everyone in the room, all right? Boost mode, be real careful with that, okay? So you use the boost mode when you're doing something like a cross-table lateral lumbar and the patient's big. If you can get by without using boost mode, that's gonna be much better, because it basically could increase your dosage for everyone by a factor of 3 to 4. When you hit that button, a lot of times it'll on the switch, on the OECs, it'll be like, it looks like an eye with a plus. Have you seen that?
Yeah.
When you hit that button, there's gonna be an audible sound. And Bob was nice enough to tell me that by law, it has to make that sound, okay? So that means there's extra dose that's coming out of that tube. So it's kind of a warning for everyone. When that plus sign when that's not activated, it doesn't make a sound when you hit that X-ray button, okay? All right, automatic exposure. Usually I found that you don't need to hit that, you don't need to change it a whole lot. Usually whatever works there will work pretty well. Again, foot pedal and hand switch. Road mapping, has anyone ever seen any road mapping? What happens here is that basically you're gonna be able to see a vessel, coming down like maybe an aortic, the aorta. And what it does is when you keep it on road mapping, it'll basically take it at its darkest, most, it'll take it at its greatest opacity throughout the whole thing. So everything is highlighted on there. It's not like the top part, the proximal, the superior part's visualized, then the distal. Basically, they'll keep it as dark as it can throughout the whole vessel so you can kind of see it. It's kind of like a car that you see a picture of a car driving over a bridge at night with the red lights. You can see the kind of the trail of lights. That's what it looks like. You're able to see its opacification all the way through the vessels. The doctors love that. Subtraction, has anyone seen that? Okay, so what they're doing, used to be a big ordeal. What they're doing is they're trying to isolate just the vessels. So the best way to think about that is visualize a map of the United States. Now superimpose all the rivers and tributaries over on that map. Now take away the map of the United States. You can see a little bit of a shadow of it, but all they're looking for is the vessels. They're not looking for the bony structures. So that way they can see any kind of abnormalities. But that's what basically subtraction. They're subtracting something from the image, and that's all the bony structures that they're subtracting, okay? And then cine loops, this is when you actually are taking a movie of it, and they'll announce that, and they're interesting to be able to watch, and of course they can play that back later. Okay, let's see. So on your monitors, just understand that you have a left and a right monitor. So this is usually your live monitor. And the way you utilize this is, let's say you're doing a cross-table lateral hip. You're doing an AP or a PA hip, and then they say, go ahead and do a cross-table. The doctors, or the surgeons always want to be able to see your AP and lateral view at all times. So you've got your AP here. They say, go ahead and give me a cross-table lateral. And there'll be a little switch. I'll just show you where this is here, okay? And it's this switch right here. In fact, let me go into this next one because it's kind of highlighted here. And it's just a left to right. And all it's going to do, it's going to go ahead and move the image from the left monitor to the right. And that's like your saved image. So then you do your cross-table lateral, it'll appear on here. They'll be able to see the AP and the cross-table lateral. Then the doctor says, okay, go back to an AP. Then you hit the button again, so they switch over. So that's going to be your cross-table lateral. And then when you do your AP or PA, it'll be on here. So that way they can see it at all times, okay? So just a little suggestion as to how to use that. All right, let me see what else is on here. So just some of the buttons here. This is AEC here. So when you have magnification, if they want it, there's a level 1, a level 2, so this is a little bit greater magnification. The save button here, sometimes, you know, again, Bob was telling me that a lot of the units will automatically save, but just make sure, if it is something where you're actually in control, they don't use the foot pedal, and it isn't saving it, one of the better things to do is it's on your control panel there. You can go ahead and save some images, like doctor says, oh, that's a good image, you know, go ahead and hit the save. And a lot of times on the screen it'll say save in that. Because this is what happens with me. What happened to me a few times is, didn't happen many, is that you go ahead and you do a case and you didn't save anything and the doctor says, I'd like to get a picture of the last 4 images you took. It's like, I wasn't saving it and it wasn't set up to save. So if you think that it might be good, like towards the end of the case, just hit that save button a number of times and that way you have it. I learned from experience the hard way to do that. If you have to rotate the image, there's your rotation buttons. There's the collimators, they're rarely used. You'd only use it when you're not gonna move the C-arm like you're doing some kind of pain management and it's in one fixed position, then it might cone it down a little bit, but generally you don't use these too much. And here's settings for the KV and the mass increases or decrease. Like I said, you're not gonna be using those too much. There's the switch for the left to right monitor. If you need to change your orientation, here's all the different, there's a regular R, a backwards R, an upside down and backwards R. So you'll need to kind of get an idea as to what to do. I've got a slide on here. Generally, when you come in on the left side, you don't have to make an adjustment. If you come in on the right side, a lot of times you have to hit the upside down and backwards R to do it. So you can kind of use this as a little bit of a guideline. But again, that comes from a little more experience. And then you have your alarm reset. So usually, Bob, is it every 5 minutes in there that it goes off? I'm trying to remember. Yeah. So when it goes off, I always would announce that's 5 minutes or 10 minutes because they'll lose track of time in that. And so, you know, it will go off and you actually have to hit it and reset it in that. So it's just a nice mechanism. Let them know that they're irradiating the heck out of that patient. So anyway, here's just some notes on when you have to go from a PA to a lateral. I know I showed Byron this and it worked, right? Worked pretty well about remember how to invert it?
20 degree.
Yeah, right, yeah. So this is something that I just kind of made up. When you went from an AP to a cross table lateral, if you went ahead and just turned it, a lot of times it would hit the table. So what I would do is kind of turn it about 20 degrees, then lower it, and then I could go ahead and get it around the far side of the table and then raise it up as much as I needed. And then sometimes you need to move that image intensifier towards the patient because it magnifies it too much. Then when you're going to go from the cross table lateral back to the PA, you just do the opposite. If you move that image intensifier in, you got to move it out. And then you lower the C-arm, you rotate it back to that 20 degrees, and then you kind of raise it up and get it back to its normal position. So, like I said, you can just kind of go by some of that. All right, on here, I wanted to mention, always watch the surgeon's eyes, especially if you're in control of the fluoro switch, because what would happen a number of times is like in pain management, you know, they would be fluoroing, or you'd be in control of this, and they'd say, keep it on, and then they would look away from the monitor. I always turned it off, because a lot of times they'll look back and they'll say, that's still on. And that's patient saving. They're not really great sometimes at telling you to turn it off. So just keep in mind, one of the techs I work with would always watch the monitor. I said, you need to watch the surgeon's eyes. Because when they look away from the monitor, shut it off, because they don't need it at that point. If they look back at it and they want it on, they'll tell you that they want it on, okay? So that's something on here. And always, whenever I was gonna shoot, like especially was a scout, I'd always make sure and just say X-ray, because people aren't really aware of everything. So, you know, just as a preventive thing to do. These next 3 slides are interesting. I know Bob has gone over it, but again, just keep in mind that you want that tube to be in the 6 o'clock position and the intensifier, the image intensifier at the 12 o'clock. That's gonna reduce the amount of dose that we get, the doctor gets, and that we get, okay? Sometimes you have to angle the tube. That's gonna be, you know, an increase of a factor of about 4 to increasing radiation in that. And then once in a while, they used to do this at our hospital. Whenever you were doing an extremity, they would invert the C-arm, so now that tube is at the 12 o'clock position, the image intensifier was at the 6 o'clock, and they would drape, sterile drape over this here, and they put the part down. That's gonna give the greatest amount of radiation. It's a lot. But just keep in mind, the determination of the position of this is not ours, it's always the surgeon. But you just kind of keep in mind that it's gonna be a lot more radiation doing it that way, okay? Does that make sense? Okay. All right, let's see here. Hey, did we ever go over time distance shielding? Oh boy, that's so important. So, yeah. And again, the key one probably is gonna be this distance. Increase your distance, that's gonna be the safest thing. But we always wanna use the least amount of fluoro, so that will help. This happens with everyone. You may slide, if you're up in surgery, at some point, you're gonna brush against some sterile area. So you might think, well, it's just a corner, no one will see anything, okay? The best thing to do is fess up and say, oh, by the way, I touched this little area. Sometimes they may say, you know what, it's near the end of the case, we're not doing anything, don't worry about it. Or they may take a little sterile drape and put that over, it's fine. If you don't do that, a lot of times what will happen is the case will go through and you don't say anything, and then at the end they'll say, oh, by the way, when you touch some sterile area, you need to let us know. Don't think they didn't see it. They're just kind of waiting at the last second to kind of do a little zinger in that. So they're watching. So just admit to it, and nothing, usually it's not, we make a bigger deal of it than they do. A lot of times no, don't even worry about it, okay? All right, let's see. So these are just some extra notes about different protocol, about how people go back to back, not front to front, if they cross, about putting everything on. One of the things here that's important is that when you start feeling more comfortable in the OR suite, the doctor will go ahead and they'll come in and they'll do it in a very methodical way, drying their hands in the 4 different corners of the sterile drape, or the sterile towel, and then they'll go ahead and put their arms through it, and they'll be like this. And usually it's the circulating nurse that has to go and tie it up. They usually have about 20 other things to do. So once you see what's being done, you can go ahead and do this yourself of helping to tie it up in the back, maybe tie it at the waist. And then have you seen it where they go ahead and hand someone a piece of paper and they do the turn? Have you seen that? Yeah. So yeah, I had one crazy doctor that actually was practicing it during the case. He didn't like the way the scrub nurse was doing it and kept turning. He was getting me dizzy in that. He was a complete nut, but he was so good they couldn't let him go. So yeah, but he was crazy. Just keep in mind that it's our job to clean the equipment. They don't have someone in there to clean that equipment, okay? If you ever have to give something to, the scrub nurse, go ahead and, you'll insert that in there, then to the plastic sterile drape and that. Keep in mind, always wear gloves when you take it out, because you'll get a couple of them that will just hand you the whole thing and it's blood soaked and it's like, I'm not touching that, and they literally will drop it onto the floor. And so always be ready, have gloves on in case they give that to you when it's blood soaked in that. Just a suggestion, okay? These are just some things. I'm gonna let you kind of read these on your own. I don't know if anyone's done any gallbladders in here. Yep. Okay, yeah. So different places do it different ways. Sometimes what they'll do, if there's the portable machine, they'll kind of kink this, or they'll put a little mark where they want the central ray. Again, they're just looking for any kind of residual stones in that. So I have some notes in that. You can kind of look through that. I'll let you read that on your own. If you do any kind of cysto, there's just some notes on that, how to do that. So like I said, I'll let you read that on your own. In terms of different fixator devices, has anyone ever seen this, what they call, bless you, a Lizarod? Do you know what that's for? You ever seen it on like a tibia? What they're doing is they're extending the bone. The bone is shortened, and what they'll do is that this is outside of the body, okay? And they'll unloosen the screws and they'll try to elongate the bone. They'll create a gap there, and then they'll tighten it back up, and the bone will fill in. And when it fills in a little bit more, then they go ahead and loosen it and pull it out a little bit more until it's reached its proper length. So that's an external fixator, and of course you've been more familiar with what they call the internal fixators, And especially when they're going in, you're doing the term ORIF, again, open reduction, internal fixation. So that's mainly, we're gonna be dealing with the ORIF, okay? All right, so again, when they do any kind of fractures in that, they'll be putting in the guide pins in that, and then they'll put the cannulated screws in there, and then they take the guide pins out and they're left with the screws. And so this is, basically what it's gonna look like right there, okay? All right, I have this note in here. I got this from someone at Whittier, who knows what he's doing. And just kind of keep in mind how you can set up the room in terms of the monitor and how the C-arm goes. But again, if you don't need it, I won't, don't worry about it. This is just some general information in that, okay? All right, just keep in mind when you do these lumbar laminectomies, sometimes the machine goes in like this. It can go over them, that's called a rainbow. Sometimes it can go under. So it just kind of depends on what they're doing. And a lot of times what you do when you do a scout, they'll put like a needle in there and they'll ask for you to go ahead and position. And you need to be able to include at least one end, like they need to be able to see the L5S1 region so they can count up. Or if you're doing cervical, you always have to include at least C1 or C2 to be able to count down. And that's what you're doing it for. And then they'll have you pull out, you go ahead and do a little bit more surgery, then they'll bring you back in to make sure that they're in the right area in that, okay? And that's oftentimes all we really need to do with that. If you have to bring in a portable, this is just saying collimate, don't keep that light open. A lot of times it just hasn't had a chance to diverge, so you don't need a huge light field in that. So like I said, just kind of keep that in mind here. If you had an extremity that you're doing with a C-arm, a lot of times they set it up this way. But again, until you reach that, you can just use that as a reference here. With this here, let's see, we were going to go over this. This is just, to mention, of course, when you do a portable, the patient may be kind of slumped over, you're doing semi-upright, and the cassette is upright like this. You need to angle, of course, with the patient, not with the cassette, or you'll get a beautiful lordotic in this case, okay? So just keep that in mind. I'm not really gonna go over a whole lot of this stuff. You can kind of read some of this on your own. One of the things that I do want to point out, and we'll go over this when we talk about a femur, is that if you have, you're not gonna be able to get a femur a lot of times on one picture. You're gonna need, you do, a 14 by 17 and a 10 by 12 light field or a cassette. So you always want to put the smaller light field or the cassette over the area of interest. So if the fracture is at the distal end of the femur, you want to go ahead and put the smaller light field over that area because there will be less divergence. Otherwise, it's going to be basically distortion, okay? You don't want to put that center ray away from the area of interest. Does this make sense? So just kind of keep in mind. I've seen sometimes where they could do a forearm and they get the whole part on there, but the fracture's up at the elbow, and they'll do a separate spot image just of that elbow because that will be distorting if you put it in the middle of the forearm, okay? All right, let's see what else is on here. Not a whole lot more. A lot of this you've already gone over in that. Again, keep in mind with the Colles fracture, that's as a patient is falling forward, so the radius and ulna will go towards the posterior part, whereas a Smith fracture, they're reaching back and they fall, so the radius and ulna will go towards the anterior part. That's how you can know, you can see which one is which, okay? I have some notes here about, techniques in that. Again, thank you for working with me today on that. Still, again, these are more techniques I have for film, but they should be pretty much in that neighborhood in that. I only have notes in here about how to set this up because, again, this is more for the beginning than that, so you don't really have to pay a whole lot of attention to it. Just keep in mind one thing I noticed whenever I would do an AP abdomen, it looks like that tube is pretty good, but you always want to stand at the foot end or whatever, because you can see, oh boy, this is not lined up. I'm going to get grid cut off. So, may look good from, when you're looking at it face on, but always look at it from the side so that you can get a better idea. Keep in mind, when you're doing a portable KUB, the images are going to appear smaller because when you do a regular KUB in the department, you've got about 3 to 4 inches of OID that's going to magnify the part. When you're doing a portable, there's basically no OID, so you're going to get more on there. okay? Sometimes you're gonna do a pelvis, and you're gonna get the pelvis on lengthwise, which you can never do in the department, but on a portable, you can do it. So generally, what I did on my regular KUBs, I'd find the top of the crest and go a little bit lower when I'm in the department, about 1/2 an inch, 3/4 of an inch, because I would consistently be clipping the pubis too much. When I did my portables, I noticed I'm getting the whole pubis. So a lot of times with the portable, I would center it pretty much right at the crest, because it's magnifying it less, okay? So just keep that in mind, okay? Don't think I need to go, there's just a lot of different trauma views here that you can look at here. If you ever have to do, we didn't have to do this today, but if you had to do, to be able to visualize the elbow and they're in this position you want to see, like either the radial head or the coronoid process, you can do what they call the coil method, and it really does work. I've had to do that, and it looks exactly like this picture when I had to do it. So it's really pretty good in that, okay? Not too much else here. I'm just trying to think if there's anything. I think you've already seen how to do a lot of these different views here. So I think we've got a lot of that covered. Oh yeah, when you have to do if you have to do like a fourth toe that I know I've shown some people how to do that. If the patient can sit upright and actually participate, you can wrap, a tourniquet around the first through third toes and another round around the fifth and have them pull in opposite directions, and all you have is the fourth toe if you're doing that. So it actually works pretty well in that. So don't fret. I know toes look always, they're kind of tough, that lateral, but if they can participate, it really makes it a lot easier in that. We had talked about this just the other day, just always keep in mind where the angle of the foot is, and if you have to improvise, because the cassette is up, you may have, in this case, I don't know if I would be angling down, I might be angling down more this way rather than across here, but again, you're probably a little bit more familiar with that already, okay? I don't think there's that much else that I really need to go over. The only one thing I wanted to show you, a lot of people would make the mistake here when they're doing the Denelius Miller, is you really need to angle up into the crotch and not across, because the opposite leg often will get in the way. And make sure that the top of your cassette is about 1 inch above the top of the crest, because the most common thing to do on this here is basically you clip this right here, okay? So making sure that that is a little bit above the crest works. Like I said, you want to angle into it, not across. That's probably the most common mistake that's made, okay? I don't think there's that much else on here. Yeah, I think we're pretty much covered with that. I just want to mention, of course, with trauma, if you have multiple traumas, just do all your APs, then do your obliques, then do any laterals or cross table laterals, and let's see what else. Oh, and then I had mentioned this a number of different times. It talks about in the book about central ray, but there's a lot of times the central ray will really throw you off, okay? So here's a lot of examples here of when you do an exam, I don't know if I would bother using the central ray. Again, using the light field on a lot of these is a whole lot better than using central ray. That's from my experience in that. So there's a number of those there, and that's it. So thank you again for staying over, and I'll send all these PowerPoints and the notes and that to you so that you have that, and keep working on those positioning charts. Okay.